Kia ora koutou katoa, ngā mihi nui ki a koutou. Welcome along to the launch of the Drug Foundation's 2022 State of the Nation report. Thanks so much for joining us. My name is Hayden Eastmond-Mein. I'm the Communications Director at the Drug Foundation. And with me today, I have Sarah Helm, our Executive Director, and Carly Mercier, our Policy and Advocacy Manager, well, it's a big report, so we're not going to cover the whole thing, but we're going to cover off a few highlights. But kia ora kōrua, thanks for jumping on. It's been a busy week getting this all finalised. But kia ora, Sarah. Maybe, Sarah, do you want to talk about why the report is important? And then I'll jump to Carly and she can tell us a bit more about how she's compiled it.
Yeah, tēnā koutou katoa to everyone who's joining us today. Just to firstly say, we have worked hard to pull this report together because drug information is really hard to come by, and so we have had to dig through a variety of sources to pull it together, from OAAs to official information that's buried in various different statistics. So we're hoping this will help to inform decision makers, inform the sector, inform the public around the kinds of interventions that might be needed to reduce drug harm in Aotearoa, which is what we're all here for. And today we're going to highlight a few items out of the report. It is a huge report with a whole array of different bits of information in there, which I think that many of you will find really helpful. So first of all, an overview and context of drug use in Aotearoa. Preventable deaths, so overdoses that we're experiencing in New Zealand, impacts of our drug laws on Māori, and some of the really harmful things that are happening for Māori in Aotearoa. Shameful is the word that came to mind. And who is being put through the criminal justice system and what for, so what is the current situation there. And lastly, we're going to touch on the medicinal cannabis scheme. So yeah, kia ora, thanks for joining us, and I'll hand over to Carly Mercier now, our Policy Director.
Tēnā koutou katoa, ko Carly Mercier toko ingoa. Hayden, you asked how we'd compiled this, and all I could think of was blood, sweat and tears. It's very hard to access all the data out there. It's in every imaginable place, and also a lot of the things that you really want to see are nowhere. So in a way, what we are also highlighting is the areas that we really need better information on in the future, and one of those was the one Sarah mentioned, which is overdoses. We really struggled to get a really clear picture of those, which we'll talk more about in a minute. So we've got some slides. Do you want to get that going, Hayden? And I'll just barrel through these first ones really quickly, but this is just to summarise drug use patterns in New Zealand. So big overview. Alcohol, our most commonly used drug, of course, 78.5% use that. And around a quarter of those who drink hazardously, which means that they're drinking in a way that could cause them physical or mental health damage. Second most frequently used drug is tobacco, and that rate there you can see has been falling over the last 5 years. So, and actually for longer than that. So, for example, in 2011, 10 years ago, the rate was 16.4%. So it's fallen really quite a lot, which is great. Cannabis use has been reasonably steady for the last few years, but has increased over the last 10 years. And we've got this new indicator in the health survey now, which is weekly use, which is fantastic because it gives us more of an indication of how people are using, not just whether they're using every year. So around 4.5% use at least weekly, and that is sort of around about 187,000 people. And overall, more than 600,000 use cannabis every year. And that's an illegal substance. Obviously, we've got huge criminalisation of a huge chunk of our population. Methamphetamine or amphetamines is what they ask about in the survey. So we can't specify how many use methamphetamine, but we can say that 1.2% of the adult population consumed amphetamines, including methamphetamine. And this rate really has remained steady for about the last 10 years and equates to around 40,000 people in New Zealand. So next slide, please. Just wanted to very quickly look at meth and MDMA use. Sorry, very busy slide, but the black is the methamphetamine use and the orange is MDMA and the grey is cocaine. And this is the wastewater data. We've just been collecting wastewater data for a few years now, so you can see really there how much use fluctuates every month for those substances, and that we don't consume much cocaine. So yeah, with methamphetamine use, the use is really spread across the entire country. Every single community has meth in the wastewater. The highest rates are in Northland, the lowest rates are in Southland, but it really is widespread, and every socio-demographic group uses it as well for a whole range of different reasons. And what's really interesting is that only around about a quarter of those who do use methamphetamine use monthly or more often. So that's only around 9,000 people are using it quite regularly, based on the health survey. There may be population groups that are missed in that survey, by the way, so it might be more than that. It probably is slightly more than that. Next, yeah, so I just wanted to point out that's really clear from the data how much, although drug use is widespread, also it's really strongly influenced by socio-demographics, where you live, who you are, gender, disability, that kind of thing. We know that, as I said, drug use is widespread, and we know that 44% of adults will all try an illicit substance in their lifetime. But socioeconomic status has a real big impact. So this is a graph of past year cannabis prevalence by DHB, and you can see people living in Capital and Coast, where I live, more than twice as likely to be using cannabis over the year as those living in counties Manukau. And this kind of thing is true for all drugs, that there's a huge disparity depending on where you live. Next slide. So age has a really big impact on whether you're going to be using drugs or what kind of drugs. If you're 15 to 24 years old, you're 8 times more likely to use cannabis than those aged 65 to 74. But the really interesting thing about this is that those in the older age ranges, that's the fastest growing age cohort for cannabis use, probably due to medicinal cannabis, interest in medicinal cannabis at the moment. And the next slide.
Yep. Am I right with people with disabilities are almost 3 times more likely to be using cannabis as well?
Yes, absolutely. So they're nearly 3 times more likely to be using it weekly. So yeah, to be using it very regularly. So methamphetamine was, I guess, one of the starkest ones in terms of socioeconomic status. I really noticed, I find this stat really affecting, that women living in the poorest neighbourhoods are 18 times more likely to use amphetamines than women in the wealthiest neighbourhoods. Bearing in mind that the stats are focused on really small cohorts of people. So, it says on the database, be careful of the stat, but I wanted to put it in anyway, because I just think that it's really clear across all the data for drug use that where you live and your gender and your ethnicity and so on is just so relevant to whether you're likely to be using regularly. And as Sarah said, also, of course, disability has a huge impact. Disabled people are nearly 3 times more likely to use amphetamines as well than non-disabled people. So this is MDMA. I just wanted to put this in again. So whereas methamphetamine use is most common in the north, MDMA use is most common in the south, in Canterbury. And in comparison to methamphetamine, the interesting thing about MDMA is that its socioeconomic status is correlated to wealth rather than to not being wealthy. So you're more likely to use if you're in a wealthy neighbourhood. Yeah.
Great. Thanks, Carly. It's really useful context. Yeah, whistle stop through the stats around use. I guess one of the things that jumped out for me in the report was just how broad drug use is across New Zealand, and as you say, it is in every community. We can't just kind of pigeonhole the issue and think of a certain type of person as a person who uses drugs, which means that we need really broad but also really specific and tailored responses, right? And I guess we're going to dig into a bit more detail on some of those issues as we go through the key points of the report. The next part of the report that we're going to touch on is preventable deaths, overdoses, and that's something that, Sarah, you've been actually talking about a bit in the media over the last couple of days. We kind of pre-released this part of the report. So, yeah, Sarah, over to you around what we've found in the report around preventable deaths.
Yeah, thank you both. And just to add to that, the drug use stats, I think the other thing for me is that reason why people are using substances. So just like alcohol with illicit substances, they're using it for pleasure and for enjoyment. And then there are other reasons that people use, including unmet health need, which might reflect some of those disability stats and some other things, and the therapeutic benefits of some of the substances that are illicit, at least at this point in our history. So to move on to some of the more distressing part of our content today is the preventable deaths content. So it has been great the last few days actually getting a bit of attention on this, because we have some measures that we would really love to see put in place. So every year we are losing something like 50 New Zealanders to opioid overdose. These are preventable overdoses, and we also literally have hundreds of preventable hospitalizations, so overdoses that don't result in death. And we are also seeing deaths from synthetic cannabinoids in many, many hospitalizations. So the numbers are shocking and it's unacceptable. And in the last year, we probably had about a dozen people pass away as a result of synthetic cannabinoids. We have a couple of interventions that we have been talking about in the media the last few days. One of which is Naloxone Access. So you may, if you've been following us for a wee while, know that we've been trying to promote Naloxone Access. At the moment, access is really patchy, so bad that late last year we worked with the Needle Exchange to do some fundraising to raise some money to buy some Naloxone to be able to give out in the Palmerston North and Nelson region. And basically, we want to see, we have two types of naloxone. One type is unfunded, but you can give it out, and the other type is funded, but you need a prescription to access it. So essentially, many New Zealanders are unable to access it that are opioid using, and it would help to prevent those 46 deaths. And then the other thing that we would really love to see in place, aside from some overdose awareness and education measures and training people into how to intervene, is particularly for the synthetic cannabinoid, people who are experiencing overdose from synthetic cannabinoid use, is a supervised, medically supervised drug use space. As we have seen around the world for many years, they're very, very effective at preventing death. And we would really love to see one trialled, wrap some research around it, make sure it's effective, but the Auckland CBD is really calling out for it. We have people who are concerned about those individuals that are in the streets at the moment, and the businesses or the residents. We have ambulance and police resources being tied up in a poor response, and we're really just kind of turning a blind eye very unethically at the moment to those people. We are currently working in with fantastic organisations like NDIB and frontline organisations to put in place sort of an early warning system on dodgy batches of synthetic cannabinoids, but it's ambulance at the bottom of the cliff stuff. We want to get further along upstream. And I'll probably stop there with the overdoses and hand back to you, Carly, on some facts.
Yeah, Carly, maybe if you can dig a bit more into the data around these overdoses, because I know that some of it is takes quite a long time to get to us and to become public, and can be quite hard to compile.
Yeah, I did want to mention about the difficulty in compiling the data, because it was a real struggle to get the data that we do have, and it's, as you say, it's quite patchy. So the timeliness is an issue for us in terms of being able to identify trends and so on in overdose deaths. I don't know that there's an awful lot that can be done about that, though, because it does take a while for the cases to go through the coroner's office, and at the moment there's quite a few years backlog. But that is an issue from a public health point of view in terms of working out what substances are currently causing deaths and so on. And the other issue around the data is that there's data held in different agencies. They don't necessarily gel up, and a lot of the codes that they use are quite old-fashioned in terms of they were probably developed before we had this a range of so many different types of drugs that people use. And so, for example, volatile substances, we know that nearly 10 people die a year, but the volatile substance deaths are sort of lumped in with the deaths from carbon monoxide poisoning. So it's really hard to actually be able to say for sure this is the number of people that die of that, and this it's going up or it's going down. So that kind of thing has been a bit of a hindrance. And the other thing I really noticed from the data that I found fascinating, if you get the lists of deaths from the coroner, you can see that nearly every single death has been, they found multiple drugs in the person's system. So it wasn't just that they'd used one drug, they'd used many. And that's really... Yeah, and alcohol as well. And it was 1 in 6, I think, had also used alcohol. And so that's really relevant in terms of harm reduction, so that we know that we can warn people specifically about mixing certain substances and the dangers of that.
Yeah, thanks, Carly. Yeah, it is a real problem when the data is maybe not 100% reliable and we don't really know the scale of the problem, and then it also takes a long time to get to us. But I mean, this is a bit of a best effort, right? We've pulled together what we can and what's available, and it is still quite eye-opening. We're going to move on now to what I think is probably the strongest theme throughout the report that I saw, and definitely one that has jumped out to the journalists that I've been speaking to about the report over the last couple of days, and that's the impacts, the really grossly inequitable impacts on Māori of our approach to drugs, of our drug laws. And yeah, it's, as we say in the intro, it's across nearly every page of the report. So we're going to run through some of those key stats around those inequitable outcomes now. I'll hand over to Sarah to run through some of those.
Yeah, thank you, Hayden. Yeah, look, I just want to preface this by saying psychoactive substances are not a Māori issue. They were introduced post-colonisation, so Māori didn't really have psychoactive substances as far as we're aware pre-contact. And so are our drug laws and policies. They've been imported from international models from around the world and foisted upon us here to great cost for Indigenous people, not only in Aotearoa, but around the world. And so we'd really love to see that be addressed. So just starting to highlight a number of the very distressing trends that I can only, the word racist comes to mind in terms of our system and the way we are currently managing our drug harm. So first of all, Māori are 3 times more likely than Europeans to smoke daily. Māori are twice as likely as non-Māori to use cannabis based on yearly prevalence, but more than 3 times more likely to use weekly or more often. And for alcohol, look, Māori drink at actually quite similar rates, but 1.6 times more likely to drink hazardously. I could probably throw in a few other figures there, like one being 1.8% more likely to use methamphetamine. However, I kind of want to jump onto the treatment, but I'm going to talk about the access to the COVID vaccination next. So in the COVID vaccine rollout, we really, it was a huge learning for me of just how unvalued our people's well-being is by the health system, not necessarily by anyone in particular, but there's a huge gap between people who use drugs, particularly people who are using drugs more heavily, and the health system, and probably much more so for Māori, because that certainly came through in the vaccine rollout. So people in AOD treatment were one of the priority groups for the vaccine rollout, yet by November last year, they were lagging behind by a country mile. Māori were, at that point, 42% of Māori in DHB-funded addiction treatment had double doses. We are in a much better position today, thanks to a lot of work from a number of organisations, both at the grassroots, actually helping to deliver vaccine rollout, but also at a national level. And so Māori and AOD treatment are now at almost 72% have had 2 doses, still trailing a long way behind the general population at almost 95%. So in terms of treatment, this stat in front of you is very, very depressing. Basically, Māori are much more likely to want help and much less likely to actually receive any. So Māori make up 37% of those receiving treatment, but 56% of those are treated in prison. And it's also really concerning to see that access to kaupapa Māori treatment services actually went down a bit in 2020. And we know that access to kaupapa Māori AOD treatment is patchy at best already. And so it depends on where you live as to whether or not you can access it. There really is also ongoing concern about the application of the law in regards to Māori, and I don't know, the law was an import, as I said before, from overseas, and perhaps what history records as being a racially driven piece of legislation to get people of colour under control, the civil rights movement under control in the States. And as a result, we've seen mass incarceration of Latino and African Americans in the States and Indigenous people all around the world. And we're experiencing that here as well. And our Misuse of Drugs Act was written in 1975 as a cookie cutter off the back of those initiatives. So Māori continue to be 4 times more likely to be convicted for a low-level drug offence than Europeans, and make up 48% of those convicted for drug possession and 61% of those sentenced to prison for these offences. We saw, police have been given in 2019, there was an amendment to the Misuse of Drugs Act to allow for police discretion, which many of you will be aware of. It's up to police to decide whether it's in the public interest to prosecute or not. And I would say police have actually been making an effort to try, based on their statistics, to try to not apply that in a racist fashion. However, underpinning it, they've decided to, them in conjunction with the Minister, have made a decision to apply it based on whether or not somebody has a prior conviction. And you know as well as I that Māori are far more likely to already have convictions, almost 6 times more likely. So those prior convictions are things like breach of bail, petty crimes, prior drug offences. So we're piling harm on harm. Māori also have far worse outcomes in terms of exclusion from school. And I think the most shocking stat of all is that Māori are 3 times more likely than non-Māori to drug-related deaths. Yeah. Very, very tragically, and I think are probably reflected very strongly in the synthetic cannabinoids part of the overdoses, and also really that inability to access help is underpinning that as well. Anything to add to that?
Thanks, Sarah. Yeah, I think what you said at the top was really important, that there's a lot of context, the biggest of which being colonization, that sits behind all this. So there's not really a silver bullet, but one thing that is clear is that our current approach and policies and laws are making all that harm worse. They're not helping. So yeah, quite a distressing and depressing finding across the board in the report, but really important that we keep talking about it. Yeah, so thanks. We're going to talk now. Sarah just touched on this about the Discretion Amendment in 2019. So Carly's going to talk about who's being put through the criminal justice system, and what for, and what difference that Discretion Amendment made. So Carly.
Thank you. So, as Sarah mentioned, we've had this Discretion Amendment, and I'll talk to that in a bit. But what we have noticed is that convictions are falling across the board gradually, but they're falling a lot slower than we would like them to be. And I think they're probably falling a lot slower than perhaps the government had anticipated when they put this Discretion Amendment into place. So, for example, in this year, we had 4,000 people convicted for drug offences, which is down from 6,500 10 years ago, so quite a big fall. But we still see several thousand people each year being convicted for low-level offences, which are possession and use offences and possession or use of a drug utensil. So we call them low-level because we think that's not what people probably think of when they think of, a drug conviction. They think of that more likely to be a dealing or a supply conviction or importing drugs. Actually, it's nearly 2/3 of all people convicted of a drug offence were convicted of a low-level offence as their most serious drug offence. So it makes up a huge percentage of the people that are still being convicted for drug offences. Make no mistake, it's still going on. Although, people often say, oh, we don't do that anymore. We really are still doing that. And that's really clear from the statistics. And as Sarah said before, 48% of those are Māori, which is outrageous. So this is the Discretion Amendment that I'll be talking about briefly. So in 2019, in response really to the synthetic cannabinoid crisis, the government put this little extra bit into the law in our Misuse of Drugs Act. So Section 7 is the section that makes drug possession and drug use illegal. And they added this bit just to remind police that they do have a discretion not to prosecute. And they shouldn't prosecute unless there's a public interest in doing so. And when deciding if there's a public interest, they have to think about whether maybe a health-centred or a therapeutic approach would be more beneficial to the public interest. So it's quite difficult. I just want to say it's quite difficult for police, I think, to decide that. I think it would be quite difficult for anyone to decide that. I like having to weigh up whether a health-centred approach would be a good one or what the public interest even means is quite a complicated thing. And I think it's really not fair to the police to be asking them to do that. And in fact, when you look at the stats, that approach is reflected in the scattergun stats and the fact that some people are benefiting more and some people are benefiting less from the discretion in a quite random way, which I'll go through. So the next slide just shows the extent to which convictions for low-level drug offences have reduced. So if you look at the 2 years before the amendment and the 2 years after the amendment, you find they've gone down 13%, which is not huge, but maybe we'll see that increase. 2021 was certainly a better year for that than the year before, and I think that was perhaps because politicians had said publicly they were expecting it to go down more, and suddenly it started to go down more. And again, it shouldn't be working like that. It should be the law. It shouldn't be sort of up to interpretation in such a way, in my view.
And it's still a lot of people, Carly? 3,000 New Zealanders being convicted for possession of a substance.
Yeah, as their most serious drug offence as well. It's not like they're also getting other drug offences at the same time. And this is really interesting. So if you had no other charges on the day, like you didn't resist arrest, or you hadn't done something else on the same day that the police caught you with drugs, then there's a far greater reduction in the number of people who are convicted. So that has gone down 37%. And again, there's nothing in the law that actually says it's more in the public interest to convict someone of possession if they've also done something else. That's just really an interpretation from the police. And then so I've written a list of some of the things that came out of the data and the OIAs in terms of what are the things that will help you be prosecuted or not be prosecuted. So as I said before, if you have no other charges on the day, you're probably not going to be prosecuted. Or if you don't have prior convictions, that's also really relevant. So noting that prior convictions that people usually have when they get a drug possession conviction are usually non-violent, as Sarah said. So they consisting predominantly of breaches of community-based orders, such as community work or home detention. So you don't show up for that, and then next time you use drugs, you're more likely to get prosecuted. And things like theft or possession of weapons or other drug offences, driving licence offences, that kind of thing. So to me, that doesn't really make sense. because it should either be illegal or not illegal to use drugs, in my view, and deciding on such random things about whether you get a conviction on a given day seems wrong to me. And the next one is to do with what drug you're using, and this seems even crazier to me. So let's look at LSD, the orange line there. That's the percentage chance you have of being prosecuted if you're found with LSD, and it's, I think, 73% chance, and that's for people who have no prior convictions. It's higher for people who have prior convictions. But if you are caught with cannabis, you've got a 12% chance of being prosecuted. Methamphetamine's 51%, I think. So the different drug you have has a huge impact on whether they prosecute you. Sorry, Sarah, you were going to say something?
Yeah, just the LSD one is so bizarre, isn't it? Because we know LSD is class A, but generally it's thought to be pretty low harm. And conversely, there are drugs like N-bomb that could be substituted for LSD that are quite deadly. And so it's quite a bizarre statistic, and one that I'm not sure if we fully understand as to the motivation for why police would bother.
I suspect it's because they have so few of them. They're like, oh, hey, this is interesting. Let's do this thing. I don't know. I'm guessing here, but the other one thing I wanted to mention about the prosecution discretion is that you're more likely to get prosecuted if you turn down treatment for drug addiction, or if you haven't responded to treatment for drug addiction and you keep offending or keep using drugs. And you're less likely to be prosecuted if you agree to get treatment. And so I really see that as discriminatory against those who need our support most, which is people that are struggling with their drug use. And I don't see why it should be relevant at all, frankly. And so, yeah, a few things to unpick in the way that the Discretion Amendment is being interpreted. Oh, yeah. Sorry about this slide, guys. This is a very hairy slide. I got this from the police report. So for each group, European, Māori and other ethnicities, you can see down the bottom an N and a Y, and that basically means has the person got a prior offence or not. So for Europeans, if you do have a prior offence, you're 62% chance of being prosecuted for a possession offence if they come across you with a drug. You can see for Māori, it's very similar rates to European. So once you're actually caught with a drug, whether or not you get prosecuted is fairly similar, except for the discrepancy Sarah mentioned before, which is that Māori have far more prior convictions on their records already. And the other thing to note, of course, is that Māori are far more likely to be policed in the first place. So they're 6 times more likely to be stopped than a non-Māori, and they're 4 times more likely to have a warrantless search visited upon them. So if you take that into account, you know, the fact that police are over-policing Māori is one of the reasons, along with the prior convictions, that means that although the police are actually applying the law the same way once they've got the person in front of them, it does mean that Māori are hugely disproportionately represented in the criminal justice outcomes. Does that make sense? That was slightly rambly, sorry, but
No, it makes sense. Do we want to touch on the impacts for young people and young people entering the youth justice system?
Yeah. Okay. So the good news is that during the 6 years prior to and culminating in that 2009 Discretion Amendment, warnings and prosecution of young people for drug-related offences have fallen dramatically. So they're much more likely now to get a youth referral rather than a prosecution. But I think it's still really concerning the numbers that we're talking about. So in 2020, there were 913 young people entered into the youth justice system for drug offences, and the vast bulk of those are for cannabis, and the vast bulk of those are possession related. So we're talking quite minor offences here, and they're being brought into the criminal justice system.
Which is quite an extreme response. I mean, we talk about 90% of them are cannabis, and 90% of them, I believe, are possession, sorry, quite the reverse. It's such a heavy-handed approach as it compared to alcohol, wasn't it? Which is, you know, not too dissimilar. You know, alcohol is actually much more harmful than cannabis in terms of impact on the body and health and other people, etc. So it's such a disproportionate approach to go and enter into the justice system as opposed to talking to the parents and getting them to have a chat to the young person, which might be a more proportionate response.
Yeah, and what stood out to me was that as soon as you put a young person in through that system, that's far more likely to impact their future and cause harm in their future than potentially the drug use that put them there.
We drive people out of the normal education system and employment and stuff. Yeah.
Okay, well, we are on to our last highlight topic, and we're ripping through it. It's great. But we're going to talk about some really interesting numbers that we found. Carly did a bit of analysis across a number of bits of data of how the medicinal cannabis scheme is working versus how many people are still accessing cannabis for medicinal purposes through the black market. And I find this one pretty fascinating. So Sarah, do you want to kick this one off?
Yeah, great. Well, you may be aware that medicinal cannabis was legalised in 2017. There was legislation to allow for the development of a medicinal cannabis industry in New Zealand and make products accessible. And they came into force on 1 April 2020. However, the medicine is still largely out of the hands of many people, and our concern for patients is that basically it's very expensive and very hard to get. And so one of two things, it's very hard to get a prescription for it. And then even if you do manage to get a prescription, the medicine is still at about $130 a month at the cheapest. If you need a more specialized product, you might be looking at more like $1,000 a month, which is well outside. I mean, both of those numbers are well outside of the hands of many, many people.
Carly, do you want to talk through what the data's shown about both the increase of supply through this new regime, but then also conversely what we're still seeing in the black market?
Yeah, so you can see from this graph, so the grey lines are CBD only medicinal cannabis products, and the orange lines are CBD, THC mixed together, and THC is the black line. So you can see that CBD products at least have increased massively over the last couple of years, though it's still a drop in the bucket of the people who want to be able to use it. And you can also see from the stats that THC products are not going up at the same rate, although hopefully that will change a bit now that some more products have been finally put on the market. But still at very, unaffordable prices for a lot of people. So we know, for example, in that around 42% of those people who do use cannabis each year use it for medicinal purposes to treat pain or other conditions. And so if you extract that fact from our current figures of how many people use cannabis overall, which is over 600,000, we've estimated 266,700 people each year are using cannabis medicinally in some way. And so from prescription records, we can estimate from there that around 6% of people who use it medicinally are actually getting it legally now, which is a great improvement on a couple of years ago, but it's still, you'd have to admit, not that great. 94% of people are still having to access it through the black market, which puts them at risk of criminalisation, makes a lot of patients really, really anxious. They may, if they do get caught, they have their medicines destroyed. If green fairies who are producing products for them get caught, they have the medicine destroyed, and that has a huge impact on patients. So not yet the ideal system.
Yeah, and we've seen some really absurd situations recently with helicopter police helicopter operations resuming in some parts of the country, and as you say, you're spraying plants that are essentially on their way to being medicine for someone or treating someone's chronic illness, which just seems the most absurd situation to get your head around, really, that we'd be spending hundreds of thousands of dollars on doing that. Thoughts on solutions? I know most people watching this might have heard them from us over and over, but how do we get ourselves out of this situation for medicinal cannabis?
I think it's an incredibly effective medicine as well, just from my own personal experience. CBD oil has changed my life. I get it on prescription. I'm lucky enough to be able to pay that amount of money compared to the other medicine that I was offered that gave me really horrible side effects. So anyway, for those people who need to access it. I think that you're always going to have a part of the population that are distanced from the health system. We shouldn't wait for the health system to catch up to where everyone is at, and we should be doing one of a couple of things. Loosening the regulations so that we're able to bring the price down even further. So it's great. We have gone from it being something like $350 a month. Like, that's how crazy it was about a year ago. So we've improved a wee bit, but keep improving that, keep improving the prescription guidelines for doctors. So we've been trying to influence those. And then lastly, to really decriminalise cannabis, so that people who are using it for medicinal purposes aren't being prosecuted, which has continued to be the case even post that section the 2019 amendment to the Misuse of Drugs Act. Carly can probably speak to more depth.
I mean, I think you summarised it really well. There are a couple of sort of policy tweaks that we could be making too, but I don't want to bore everyone to death with that. But it's things like aligning our product standards with the international ones, because at the moment it's really hard to get a product approved, and that's meant it's taken years to get products on the market. And you obviously need more and more products so that you can bring the prices down. So there's things that the government could be doing around that, I think, to speed that process up a wee bit.
Great. Thanks both. Well, we've reached near the end. I want to spend the rest of the time we have doing a couple things. I want to give people the opportunity to throw any questions they might have in the comments, and we'll try and get to a couple at the end if we have time. But I'm keen for some kind of some overarching thoughts about what this report says, what we need to do, where to from here. But also I'm aware that the world at the moment is can be a bit of a topsy-turvy and gloomy place with what's going on around us, and this report certainly adds weight to that and is gloomy in and of itself. So I'm also keen to hear from both of you, what you are actually feeling positive about and hopeful about, not just out of this report, but what you've been seeing around the sector and around the motu. So Sarah, we'll start with you.
Yeah, I mean, I think that's a really good point, Hayden. And it is really hard at the moment to constantly be bombarded with difficult news and conflict and various, the anxiety we're all feeling about COVID, whatever our thoughts are on it. Look, I think there are a number of really positive things that have happened in recent years, actually. Dating back to, of course, the 80s with the creation of the needle exchanges, which was such an effective public health intervention and has been, the jewel in the crown in terms of harm reduction for a long time. We then had to wait decades, of course, for the next drug-related harm reduction initiative to come into being, but that's been drug checking. And thanks to the really hard work from Know Your Stuff over many years, putting themselves at risk, as well as some of our colleagues in the Drug Foundation, my predecessor, Ross Bell and others, have worked to get that legalised, and I should also acknowledge parliamentarians in that effort. Look, and I think that's been incredible. That has really shown some really, that harm reduction does work, and it's also given us a really good case study for people to see that a different approach might actually produce a better way of doing things than we're currently doing, just leaving people to their own devices and hoping for the best. And up north, we also have Te Aotearoa, the methamphetamine work that's happening there, which has shown some really, really promising results, which we might speak some more to in coming days or weeks. And I hope that we continue to grow that program. There was an announcement late last year that will be extended to Bay of Plenty. It needs a hell of a lot more funding to do the job properly, and there are some other locations that would really benefit from that project. But those three items, actually the early warning system, I should also acknowledge the great work of NDIB, Diane's, and the Drug Foundation, all the organisations we work with. I think that all of those are such great positive examples of Aotearoa doing it our way and getting ahead of the curve and creating homegrown solutions that work for us. And in other areas we're lagging, and I think we could do a hell of a lot better. So around the world, we're seeing the other positive thing that we're seeing is we are seeing law reform happen. We're seeing decriminalisation in so many countries now. Malta, Mexico, parts of Europe, many states now have at least decriminalisation, if not legalisation. ACT and Australia are looking at a couple of things. Canada has legalised cannabis and they're looking to decriminalise all drug use. So, you know, it's really time for New Zealand to, I don't know, do what maybe has been too politically hard, too difficult, put in the too hard basket, and address some of these huge issues we're raising today. It wouldn't fix all of them, but it would give us a much better framework. At the moment, that law even prevents us from doing some of the public good stuff that we would really love to implement, and we know would help to prevent harm and death.
Yeah, and I mean, it's interesting what you say about New Zealand, you know, carving our own path, because if there's one thing that our COVID response has taught us is that we can do that, and we can lead. We don't have to follow the rest of the world necessarily. Carly, anything that Sarah hasn't touched on that you're feeling positive about?
Yeah, Sarah has said most of the things that I would have wanted to highlight as well, especially the early warning system and the drug checking. But I also wanted to highlight, I think, something that really heartens me is the fact that New Zealanders are so much behind this. And I think since the cannabis referendum, especially, the narrative, the public narrative around this has really ramped up and changed for the good. So people are really understanding now that drug use is a public health issue, that it's a health and social issue, and they understand public health better now as well, thanks to COVID. And I think, like, we did Helen Clark Foundation did a survey just after the referendum, and although we didn't win the cannabis referendum, around 80% of people overall want some kind of law reform for cannabis. So they may not want a full legal model, but they do want to see it decriminalised. And so there's a huge appetite for law reform, and we just have to get the politicians behind that and get them feeling brave enough to actually take action and do that. And I do feel really, really happy about that, at least.
Well, kia ora kōrua. Thanks so much for your time. I've seen lots of really great comments come in, but no specific questions. I'm going to put that down to us being really comprehensive in our coverage. There is a lot more to the report than what we covered today. Carly and others in the Drug Foundation have worked tirelessly to pull it together over a long period of time. So I do encourage you to click the link in the comments if you are interested. It's really fascinating, and also I really hope that it will be a good basis for all of the drug issue conversations we have this year. It's a really useful kind of benchmark of fact and statistics, so that you know, we know how scarce facts and reality can be sometimes in this crazy world. So we'll leave it there. Thanks so much for joining us. Sarah, do you have a final thought?
I just also want to thank all those lovely people in the public service that furiously answered our OAAs. I have worked in the public service, and I know how hard that is. But also I want to thank our staff. So Carly Mercier, who's worked tirelessly to pull this together alongside Helen Jarrett, and a number of other staff like Natalie and Zoe and yourself, Hayden, that have pulled the comms together, and Emily and others. I'm probably going to miss some, but it's been a huge effort from a number of people to pull this together. And I also want to acknowledge our partners, Te Rau Ora, and assisting in some of this as well. Yeah, kia ora kōrua.
Kia ora. Well, yeah, thanks again for joining us, and yeah, please do continue the conversation in the comments. Hit us up if there's anything you have questions about or any comments you have. But thanks very much for watching. Ka kite.
Thanks, everyone.